Today is a look back at CHQI over the last 6 years and a preview moving forward, specifically what we're engaged in that supports the advancement of the UC Health enterprise. And a little bit of a background for those of you who don't know about CHQI. CHQI really started out, it's a great experiment. It was a vision that was held by the 5 then CEOs of the medical centers, Dr. Stobo and Santiago Munoz, who's now at UCLA. And it was really designed to identify and scale high-quality initiatives through grant awards. We started with $15 million in funding. We were then given another $10 million from Risk Services, and we had 52 grants that were awarded between 2011 and 2015. Historically, the objectives of this colloquium, was to present grant and grantee work. This year, the focus is going to be sharing CHQI's overall impact, what worked, what didn't, and feature some of our grantees. As you can see from the timeline, though, we're not just a grant-making organization any longer, and we've grown beyond that as UC Health has grown. So we're moving to what I'm terming CHQI 2.0, growing as a system-wide entity as UC Health grows. We hope you find today to be compelling, informative, and thought-provoking as we talk about UC Health within the current national healthcare environment, which is confusing at best, but we think also creates opportunity, hence our focus today, UC Health and the National Quality Agenda and Opportunity. And at the risk of stating the obvious, what's going to happen in healthcare is a big unknown, at least on the federal level. However, while the feds are playing repeal and replace tug of war with the Affordable Care Act, we're lucky enough to be in California. It's a pretty like-minded and independent state, and we have a lot of, at UC, unrivaled scale, size, and a sphere of influence across our 6 systems. And we do think we're bigger than everybody else. We also have a very big database of 15 million patients and growing, representing, if you're doing the math, nearly half the population in the most populated state in the country and in the 6th largest economy in the world. Our population is representative of populations across the country, so most of what we learn is generalizable across the country. And as the saying goes, as California goes, so goes the rest of the nation. So in addition to our size, our scale, our reach, and our big data, collectively we have more mind power, the best researchers, state-of-the-art resources, and more providers representing every and all specialty and subspecialties than any other system. We have, not to overuse a word, a huge opportunity. We have everything that's necessary to determine and lead the national quality agenda, and quite frankly, we should be doing just that. The opportunity is ours to lose. My personal goal for today is for everyone to walk away with an aha moment. But what we'd love to see is for the leaders of the medical centers to work together and identify and implement an aspirational improvement effort. If you leave committed today to developing a new system-wide initiative or growing existing initiatives, then we've done our job. And it is now my pleasure to introduce my boss, Dr. John Stobo, the Executive Vice President of UC Health.
As Karen indicated, this is a moment to pause, to look at what's happened with CHQI over the last 6 years, and then decide what we would like the future of CHQI to be. As Karen mentioned, this was an experiment 6 years ago, where the CEOs of the medical centers decided to invest in an activity that would come out of our office and the Office of the President, but would identify best practices throughout the system, fund those practices to prove the concept was valuable in terms of adding value to the quality and affordability of healthcare, then try to spread that practice throughout the system. And in your packet, you have a review and evaluation of all the grants, some over 50 grants that were funded. And Mike Ong and his colleagues have done a great job in looking at what those grants have been able to accomplish, the return on investment, which is significant, somewhere around 2.5 to 4, depending on how you look at it. There's over 50 publications, peer-reviewed, that have come from that. The return on investment includes grant money that has come in, and out of all the grants, $8 million of the $13 million comes from the National Institutes of Health, so it's a peer-reviewed activity. There is a significant amount of money that has come in as a result of cost savings and quality improvement. So I think by any measure that we've looked at, the Center for Health Quality and Innovation has been successful in its first 6 years. But now it's time to take a look and decide what the next 5 or 6 years is going to be, and we appreciate your input into that. What CHQI has done is consistent with a goal of UC Health, and that is to promote and facilitate system-wide collaboration so that UC Health-related entities and activities can more effectively carry out their clinical service, research, and educational activities. And to do this in a manner so that the system-wide and local strategies don't compete with each other, but in fact complement each other. The idea here is not to have a system-wide strategy supplant or replace a local strategy, but make sure that it complements it and it builds on it. And similarly, we want to make sure that a local strategy is complementary to the overall system-wide strategy and doesn't compete with the system-wide strategy. CHQI was probably our second system-wide activity. We've had several over the past 10 years. Probably the oldest is our system-wide contracting with commercial and public payers being Medicare and Medi-Cal. And that activity has been very successful with all the 5 medical center campuses participating, but making a final decision as a system that we are either all in terms of a contract or we're all out in terms of a contract. And that's been very helpful in our obtaining what we think is fair reimbursement for the services we provide. When we're evaluated by rating agencies, Standard & Poor, Moody's, Fitch, et cetera, we're evaluated as a system. We're what's referred to as an obligate group. So when UCLA, for example, wants to go to the debt market and borrow money, the rating agencies don't simply look at UCLA, but they look at the combination of UCLA, Irvine, San Diego, Davis, and UCSF. Now, that's good and bad. It's good because it allows them to look at us as a system, but we have to make sure that an individual campus is performing reasonably well so it doesn't drag down or have a negative impact on the other campuses. So it's a system-wide approach to borrowing money. A couple of years ago, actually 2.5 to 3 years ago, we started our system-wide cost reduction strategies, which we refer to as leveraging scale for value. They were focused on 3 areas initially, information technology, procurement, and revenue cycle, and they have been enormously successful. Over the past 2 years, the combined savings has been $552 million for 2 years, which is consistent with our projected savings of, as a system, we need to come up with between $200 and $250 million of savings each year for the next 5 years, or a total of $1 billion over 5 years. And it's been looking at best practices in terms of revenue cycle, procurement, or information technology, and then spreading those throughout the system that's enabled this to happen. We have now extended those to look at labor productivity and to look at a system-wide approach to Medi-Cal. A collection of clinical data, as Karen referred to, the 15 million unique patient medical records that we have phenotypic data on, collected as a system. And Tommy Andriola and Atul Butte have been leading that. And we now need to access and use that data to make evidence-based decisions ourselves within UC Health and the UC system as to what we should be doing in terms of improving quality and ensuring affordability. The governance by the UC Regents, after several years of discussing this with the Regents, we now have a separate committee of the Regents called the Health Services Committee, which has 7 sitting Regents, but 4 outside advisors who come from the world of academic medicine, and have been very helpful in helping us evaluate various projects and activities that we want to bring forward. It also has 2 chancellors, so the chancellors are involved in understanding what's going on with UC Health, and 1 representative from the Faculty Senate and myself. And the Center for Health Quality and Improvement that we're here to talk about today. As I mentioned, I think it's been very successful over the past 6 years. Our task today and our challenge today is to decide how it can continue to be successful and advance system-wide what we want in terms of quality, affordability, accessibility, and in a value-based world, the value of the care that we deliver. And my own feeling is that we really need to take a hard look at the data we've accumulated, the clinical data, and not only the phenotypic data, but looking also at accumulating genotypic data that allows us as a system to do innovative things in terms of delivery of healthcare, education, and research. So these are just a few examples of what we've been doing on a system-wide basis, which I think has brought great power to UC system and has advanced not only what we do system-wide, but advanced what occurs at the individual medical center campuses.